Hello, everyone, and welcome to an education program to improve interprofessional collaboration between interpreters and clinicians in advanced care planning. This is a joint collaboration, but I will tell you about this in just a little while. I would like to do the introductions first. So my name is Anna Kenny. I am the training coordinator for New South Wales Healthcare Interpreter Services. My background is Polish, so throughout the session today, I will be referring to some Polish examples. And with me have today Kylie Ash from Advanced Care Planning Australia. Kylie, would you like to introduce yourself?
Certainly. Thanks, Anna. So my name's Kylie. I have a background in nursing and I've come to you today as the Education Coordinator for Advanced Care Planning Australia. So it's great to be working in this space because my background is also working in cancer care. So this is great to come here and speak with interpreters in this context. Thanks, Anna.
Thank you, Kylie. Let's get on with the program. But first, acknowledgement of country. We acknowledge the traditional custodians of the various lands on which we all join today, and any Aboriginal and Torres Strait Islander people attending this meeting, or rather an education session. We pay our respects to elders past, present, and emerging. Over to Kylie.
Thanks, Anna. And I just wanted to acknowledge that this may be sensitive and potentially an upsetting topic to consider, but it's really great that you're here, open to learning and to this discussion. And if it does raise any concerns for you, though, please access some of the supports that are listed on your screen or some of your colleagues' support as well.
Mm-hmm. And just a bit of an explanation of how this program came about, and that this is a collaboration between Macquarie University, New South Wales Healthcare Interpreter Services, and Advanced Care Planning Australia. So this is all as a result of research which was funded by the Cancer Institute, and the project I was awarded to project lead, Professor Reema Harrison, and the educational content for this particular presentation has been prepared as a collaboration between researchers from Australian Institute of Health Innovation based at Macquarie University, New South Wales Healthcare Interpreter Services Professional Development Committee, which is where I belong, and the Advanced Care Planning Australia, where Kylie works. And over to Kylie again.
Thanks, Anna. And really, it's this iCanPlan program, which has been co-designed as part of that 3-year project, which was funded. And the aim really was to enhance the interprofessional collaboration between clinicians, interpreters, to really improve that uptake of advanced care planning among people from culturally and linguistically diverse backgrounds. iCanPlan comprises 2 components: the education in advanced care planning and facilitated feedback sessions. This education session is the first component of the iCanPlan program and consists of the 6 topics which will be covered today. And really a key driver of this work has been the inequity of end-of-life care related to health outcomes experienced by people from ethnic minority backgrounds. And this may include poor pain assessment and management. Often they are more likely to receive intensive care at end of life as well. And there are recognised challenges with working with ethnic minority communities in cancer care. There potentially is a negative perception of cancer and diverse expectations around what treatment can achieve. There may be perceptions that advanced care planning is really more set in Western principles of individual autonomy versus the non-Western collectivist culture of family-oriented decision-making. And also another thing that we'll be looking at today is sometimes there's unintended misleading of literal interpretation of some of the medical terms used in oncology and palliative care. So it's really hoped that this interprofessional education program and improved collaboration between interpreters and clinicians can support quality advanced care planning communication in this space into the future. Anna.
So what are we going to talk about today? You can see quite a few topics on the screen, and we've already covered the background and introduction to the iCanPlan program. And we will kick off with an introduction to advanced care planning, which Kylie will take you through. And then we move on to more about topics related to interpreting in the ACP communication. So the role of the clinicians and the role of the interpreters. These are all subtopics under the big topic of collaborations of clinicians and interpreters working in ACP. So we'll look at some challenges and ethical dilemmas for interpreters, some consumer expectations, some challenges related to terminology, and also at managing and coping with emotional content in ACP communication. So starting off with what is advanced care planning, an introduction to ACP by Kylie.
Thanks very much, Anna. So this presentation is for the purposes of sharing information in relation to advanced care planning. It's going to be quite general in nature, and if there are any specific questions that are around the legal elements, it really is appropriate to seek professional advice for the specific circumstances at hand. I will be making reference in this presentation, though, to New South Wales advanced care planning processes and documents, acknowledging that throughout Australia there are different laws and processes. Next slide. So what are we actually talking about here? And the purpose of this presentation today is really just to give you a snapshot and an overview. Advanced care planning considers future healthcare, as can be seen and it's around choices. Person-led, the person's choices are going to be central to any conversation and documentation. And it's really about supporting adults at any age or stage of health in understanding and sharing their personal values, life goals and preferences regarding that future healthcare. Advanced care planning can sometimes centre on medical treatments and interventions, and often though it is about other things that people consider important. And ultimately, the goal of advanced care planning is to align the healthcare that a person receives with their preferences for care if there comes a time that they can't communicate or make those decisions. This may be close to the time of someone's passing as they become more sick, or it may be due to an accident or a short-term illness, and the person may still recover. So why is this important then? If a person doesn't speak to anyone about their wishes or document their preferences or instructions, and a time comes when they do become seriously ill or injured and can't communicate or make their decisions, doctors will make treatment decisions based on their assessment of the person's best interest. They may talk to people who are not who the person would have chosen to consent to medical treatments. This may include treatments that they didn't ever want. So advanced care planning really benefits everyone. It supports the person to make some decisions about healthcare now so that their wishes and preferences are known into their future, and really about empowering that person with a voice. It helps to ensure a person receives the care they actually want. It can also improve ongoing and end-of-life care and perhaps reduce unnecessary transfers to acute care or unwanted treatment. And families and carers of people who have done advanced care planning, it's been demonstrated in the research that they can actually experience less anxiety, depression and stress, and are more satisfied with care. So it really speaks to that much more improved bereavement journey. Next slide. We say at Advanced Care Planning Australia that it's never too early, but it can be too late. So really the messaging is advanced care planning should occur as early as possible. And particularly it's important if patients have specific values or beliefs or preferences which are going to influence perhaps the health treatment decisions in their future. Some examples of this may include people of Jehovah's Witness faith who may have specific requests around blood products. For Aboriginal and Torres Strait Islander people, ties to country may be important and may influence decision making at end of life, where care is delivered, ceremonies they'd like included, inclusion of traditional medicine. For LGBTIQ+ community members, broadly it may be about ensuring chosen family are recognised as substitute decision makers, ensuring that their presentation is maintained, for example. Next slide. So when we're looking then at advanced care planning, it really is a process. It's a process that someone may dip in and out of. It's not necessarily linear. it doesn't always rely on every single step being undertaken as well. It's certainly not all about the documents being completed. It's really respecting the person's readiness to have these conversations and think about these things and going at their pace. So when we look at the parts of this process, we're looking at supporting the person to think about what is important to them and perhaps who they would like as their substitute decision maker to speak for them. We work with them to perhaps talk with trusted friends and family and healthcare providers about those specific choices. We can support them to record their wishes if they'd like to in formal documents. And then it's best to share these documents to make them available if and when they are going to be needed. And of course, the person can revisit each part of this process and they can change their mind and they can review and updated previous conversations and written documentation. And really what we'll concentrate on today is that conversation, which is when the interpreters are most commonly involved. And I'll also highlight the New South Wales official documents, which you may be involved in terms of site translation. Next slide. So initiating the conversation isn't always easy for anyone. And this is a conversation prompt which is shared from Advanced Care Planning Australia for both health professionals and community members to use. And it may give you a sense of what some of these conversations may look like from the perspective of the person who you're working with. They may say phrases like this to a health professional. So it's probably going to be worthwhile you actually accessing these conversation starters, which are available on the Advanced Care Planning Australia website. Next slide. So we'll just look then at what these conversations may actually look like. So sometimes they can centre on medical treatment interventions, but as I noted, many times it's other things that are more important to people. And it might be such as listening to your favourite music, family being present during consultations or personal care, even having pets if close by is becoming really important if these are important members of the family and their close network of support. There may also be need for consideration of cultural and spiritual beliefs and the need to continue rituals. So these are quite rich and deep conversations that a person may be having. And when having these conversations, the communication approach should be really focused on being empathetic, non-judgmental and patient to allow this conversation to flow. And key qualities of this style of communication include compassion, attention, sensitivity and being gentle, curiosity and being humble as well. And these qualities can really create that atmosphere of trust and openness, encouraging that honest communication. So I do just want to change gears now, though, and touch on when documents perhaps are going to be prepared. And really the purpose of recording wishes and preferences and instructions is to bring confidence and certainty to that time when it comes to perhaps make decisions for someone. Noting that this is a voluntary process and sometimes just a conversation is what some people are going to want as part of this process. To support people document their wishes, though, you will need to become familiar with the documents that are recognised in your state or territory, and so we will discuss the New South Wales document today. There are some key points, though, that are relevant to all advanced care directives. They must be completed in English. There are values and instructional parts to the form. Neither of these are compulsory. But I will say that the values and preferences statements are really quite important to prepare a substitute decision maker for those future healthcare decisions and give some context perhaps that sits behind what some of the decisions are that a person may have made. The instructional directives are legally binding and people really, they need to work with their healthcare professionals, and this is part of this conversation that you may be involved in, to really understand what those future health conditions and experiences the person may have in the future, the treatment options that might be offered for them, and what sort of decisions they're going to need to make, and any consequences of those decisions. When documenting, it's really important that people are trying to be as clear and specific as possible and include details about the circumstances in which they are actually consenting to or refusing specific treatments. And there are specific witnessing and signature requirements in the documents nationally. In New South Wales, whilst it's not legally required, it is recommended that one witness and a doctor co-signs the form. And this is really an important principle when an important principle is also that a person must have capacity at the time they complete their advanced care directives. So in New South Wales, common law advanced care directives are the only advanced care directives that are existing, and they are legally binding. In addition to identifying personal values about dying, an advanced care directive can be used to refuse or request treatment, particularly treatment at the end of life. And so if a person with capacity has made a common law advanced care directive giving direction about their health care or medical treatment, that decision or that direction must be followed if the person then has no longer has decision-making capacity. And it has to relate, though, to the medical treatment or the healthcare situation that the person finds themselves in. So that's really important. In New South Wales, you can also appoint a substitute decision maker to be your voice if you lose capacity. And this is an enduring guardian that can be appointed through the New South Wales trustee and guardian or through a lawyer. And I'll speak more about this role after we cover the Advanced Care Directive documents. So this is the document that is recommended in New South Wales. As I mentioned, you might like to become familiar with this document. Anna, did you want to comment on some of the findings which really reinforce this as a need for interpreters?
Yeah, so as a result of the iCanPlan research, we found out that sight translations could be a challenge for interpreters working in the space. So that's why it's important to become familiar with these forms so that you can be prepared in case you're required to do a sight translation. And Kylie will take you briefly through this form. However, you've got a link here on the screen. So we recommend that you have a look in your own time and have a go at sight translating so that you are prepared for what comes up in this form, and also in relation to any terminology that you might need to research on a little bit more. So if you are faced with sight translating one of these forms, you're prepared for it, and it's going to go as smoothly as possible. And I just wanted to give you a reminder at the same time, because what we're looking at here is sight translation / filling out forms. And particularly in New South Wales Health, we've got some rules around both of these tasks. So one of the rules is that the health professionals, the service provider, always must be present when the sight translation happens. An additional consideration when it comes to filling out forms is that the interpreter can sight translate the form and can interpret the questions that the answers that are coming back from the patient. However, as interpreters, we're not allowed to write on these forms. And of course, our clients can't write in English, because if they can't speak English, they can't write in English either. So the service provider will need to then write down the answers to these questions. So the person will give the answers in the language other than English. As an interpreter, I interpret this into English, and the service provider writes the answers down in English on the form. So that's how it is meant to work. Shall we go to the next screen?
Brilliant. Thanks so much for that summary. Yeah, this is just a summary screen. You can see the sections there, and just reminding the goal is to be as clear as possible. I will say that, though, this is a really interesting document, and there are some example statements within the document that might actually also be worthwhile just having a look at this downloaded online. So it's more than just the form. It's actually a bit of background and example statements, which you might find useful to review. Yeah, next slide. So the first part of this form really is around the details, or the person's details, and also around some information around who has been identified as the person responsible. So that's a space there to be completed. In section 2, so the next slide, these are options for people to consider around 6 specific values statements. This is really getting down to the values and preferences. So for example, if I can no longer recognize my family and loved ones, I would find life, and then there's 3 spaces where a person can tick or sign either for bearable, unbearable, or unsure. So worth having a look at those statements, just to become familiar with those as well. And in the next slide then, these are where you can actually look at the place of care can be considered, and it might be also where the person may wish to specify the role of other people in their care, what type of music they'd like played, is privacy important, value statements that they might want to consider there, and also spiritual or cultural considerations. There's some free text space that can be used also. So then in section 3, this is where the person can specifically specify either refusal or acceptance of medical treatments. You can see that it relates to CPR and some other treatments as well. The person might be prompted to think about here, as I mentioned, their current health, future health decisions. But we do know that it can be difficult if there's uncertainty around future health issues and the decisions that might need to be made. So really, again, putting a lot of detail in those values sections so that people reading the document can really get a sense of what is important for that person. Section 4 allows the person to consent to or refuse organ, tissue and body donation. And I will just make another note on this one. There's lots of boxes on this one. I've actually had recent conversations with some New South Wales clinicians, and they just wanted us to bring to their attention that these boxes should be initialed, not ticked. It's very tempting just to tick a box. Quite often that's what's happening. And also there is a signature there at the bottom that if a person does not wish to complete the section, then they should sign that point. It's not it's not for when they've completed it, they sign. It's actually if they don't want to complete the section. So some of that fine print is just worth taking a note of. Next page. So this is the section 5 is the authorization, and whilst it's not legally required, it's strongly recommended that a witness co-signs this advanced care directive. And there's no formal spot for an interpreter to actually sign, but advice from the New South Wales Department of Health is that an informal notation can be added to the document to indicate that an interpreter was involved in the completion of this document. So moving on then from the actual document, and what I wanted to just cover briefly was around this idea of the substitute decision maker and who can make decisions when a person can't make their own decisions. So in New South Wales, if a person completes a common law advanced care directive giving direction about healthcare or medical treatment, as I mentioned before, that direction should be followed. A substitute decision maker is not necessarily needed if the decision has been made and is relevant to the circumstances. But it is good practice to consult that person, the substitute decision maker, to help healthcare providers understand an advanced care directive. There may, though, be circumstances or decisions that need to be made which were not considered in a person's advanced care directive. Then a substitute decision maker will be involved in consenting to or refusing health care. And in New South Wales, there's a legal process to identify who this person is. At the top of the hierarchy is the enduring guardian, and this is the person that was appointed by them through that legal process that I mentioned at the start. It could also be a guardian who's appointed by the New South Wales Civil and Administrative Tribunal. It's one or the other. The enduring guardian or a guardian is at the top there. If neither have been appointed, a person responsible, so that is the actual term, person responsible, and that person could also be called a substitute decision maker, they'll be identified according to a hierarchy on the screen. And this may not be the person that they would have chosen. So I think that's a really important key point to consider, that it is worthwhile a person actually really thinking through and perhaps appointing someone who they want to speak for them, because otherwise it may be someone that they're not comfortable with. Now, we'll just take this moment, Anna, just to reflect on that some of these terms are quite specific and may need quite a considered approach to interpret accurately. Would you like to comment on that now?
Yeah, so the most interesting term that stands out for me on this page is the enduring guardian. So I would like you to stop and think, but we are going to come back to this in the next section. How would you say enduring guardian in your language? Because first of all, well, I'm sure that an easy translation of this term does not exist. Perhaps the concept doesn't even exist. So the first part of finding the right term is to actually understanding what it means, and then finding the right equivalent in your language. So in the second part, I've got a little exercise because I've actually gone down the path of trying to get the right term for this in the Polish language. And I'll show you the steps that I had to go through to make sure they actually have the right term for it. Looking at the other terminology, I'm sure that you will have some equivalents for them, because guardian, for example, is a more common term. And of course, spouse and carer and family member or a friend, we most of us know how to say it in the language other than English. But the enduring guardian is the most interesting one. And terminology is one type of challenge that we're looking at in the second part of today's lecture. So thank you. We'll come back to that idea.
Mm. It's a really important one. And you note there, Anna, the enduring guardian term. In each state and territory, there is a different terminology for that role that is appointed. So being very mindful that if you do move states and work in other states, that there's a lot of considerations around that language. Yeah. Thanks for that. I think we'll just finally wrap up then and just give that sort of quick overview again, just in a wrap up. Advanced care planning, really importantly, it is voluntary. It's something that the person should not be pressured to participate in. They're invited to participate in this conversation, which is an ongoing conversation. The point at which you're involved in interpreting, this may only be one conversation that's been part of a series that the person may have had with family, friends, other health professionals along the way, and it can continue on beyond the conversation that you have as well. It should be completed by an individual, or led by the individual, and their words that are being included in advanced care planning. It may or may not involve legally binding documents, and it's really ultimately for that time when the person is unable to communicate and make decisions, so that the care that they receive is aligned to those preferences and values that they have communicated earlier. Thanks.
So thank you, Kylie. We are going to move on to the interpreting section. Kylie's not going away, so she'll be there to consult, and I will take the lead role now in taking you through some of the interpreting challenges and some of the strategies and tips how to deal with these challenges in advanced care planning. So we will look, just to remind you again, we'll have a look at the role of clinicians and interpreters in ACP communication. We'll look at some challenges and some ethical dilemmas. We'll look at interpreting ACP communication, perhaps in the absence of low equivalents sometimes. And lastly, at managing and coping with emotional encounters. So first of all, we want to show you what the ACP process and conversations may look like. And as Kylie was saying, it's a whole process. It's not just one point in time, but there could be different encounters. So you're going to see a video that shows you one patient's journey through this communication. And while we're watching the video, I would like you to consider the following questions. So what would these kinds of conversations be like for you as the interpreter? What could some of the potential challenges be for you interpreting these conversations? What would the conversations be like for someone from your country of origin, so the other side of the coin? What could it be like for them? And would these conversations be similar or different depending on the languages and cultures of the different countries that the patients might come from? We'll come back to these questions and after the video.
There we go, you can have your finger back now. Thanks. Michael, it's really good that all your tests are stable, your CAT score's stable, all your blood tests are stable. It's really good to see that you're looking after yourself. Michael is visiting the practice today to review his chronic disease management plan. After my initial assessment, I checked with him to see if there were any other concerns. At these appointments, aside from checking out what's happening with your body, we also like to give you the opportunity to tell us what's concerning you so we can help with that. So is there anything concerning you?
I must have been a little worried about what happens if something at home happens. What does she do? ring an ambulance? I don't know if I really want that. I would like to stay away from hospitals as long as I can. But then, if I get seriously ill, is it going to be too much for her?
I can understand why you'd be concerned about that. Some things we can do. We can put you in touch with some community services, some palliative care or some home nursing services that might be able to help you at home.
No, I don't think we need that yet. No.
I can understand that. But what about if you did fall? What would happen?
I don't know.
Something you could be thinking about now would be someone who could speak on your behalf if you couldn't speak for yourself.
Well, wouldn't they just ask me?
Yeah, they probably would. But you need to know what's important to Michael, what sorts of decisions you'd be making on his behalf.
We've talked about that.
That's really fantastic. So Sherry would know what you'd want if you did collapse and if you did need to go to hospital?
Well, we haven't really talked in that detail yet because, we don't know what's going to happen.
Yeah, it's hard to know what's happening in the future. None of us have got a crystal ball. Mine's broken. It is important to have a chat about that. It's important for us to know what you would want so we could act on your behalf.
Right.
So you've already obviously started the process. You're thinking about it, and that's the first step. The next step is to talk with someone about it. You've started talking with Cherry. Yeah. That's really great. The next part of the process would be to formally appoint that decision maker, someone who could speak on your behalf if you couldn't speak for yourself, someone who's confident, who knows what you would want. Mm-hmm. Yeah. The next part of the process is to write it down. Writing down what your wishes would be if you couldn't speak for yourself, so we can all work off that same page, and then sharing it with the healthcare team, so with the hospitals, with anyone else who's caring for you. It's not written in concrete, it can change as things change for you at home, as your health changes. So what we can do for you today is to give you some information to take away, maybe a form to fill in. You can think about it and have a chat with each other. I can record it in your notes so that you can bring it up with the doctor next time you're here. Would that be okay?
Yeah, no, that sounds good.
Yeah, that'd be great.
It does sound good. Yeah.
Some weeks have now passed and Michael has returned to request a script. The nurse had mentioned to me about Michael's concerns and that she had brought up the topic of advanced care planning. It was important that I continue the conversation because these decisions need to be talked through over time. I see from the notes that Mary made that you were speaking to her about making an advanced care plan?
Yes. We decided Cherry would be my decision maker and say if I collapse at home, she'll call an ambulance. But she's not going to allow the doctors to put breathing tubes in.
Right. So did you appoint Cherry as your decision maker?
Yes, I did. Actually, I've got the form here. Is that okay?
Okay. Yeah, this looks like it. Is it okay if we keep a copy here?
Oh, of course.
So have you and Cherry had a chance to talk about what you would value most, so that it might help guide her to make her decisions?
Well, she knows I don't want the breathing tubes in. What else should we be thinking about?
Well, it might be a good idea perhaps to get all three of us to make a time to get together to talk through some of this.
Right.
I can discuss some potential outcomes with you and then you can let me know what you might decide. At the next visit, we discussed Michael's values and preferences for care and completed all relevant documents. The instructions included that he didn't want intubation, but did want IV antibiotics. A copy was included in our practice records.
It's now 6 months later. Due to a chest infection, Michael's health has deteriorated further. Recently, an ambulance was called to Michael's home. He was having trouble breathing, and Cherry and Michael decided to make the call to take him to hospital. He's now recovering, things are looking okay, but what's really worrying Michael is if Cherry can continue to manage his care. How's Cherry going?
She's okay. She's well, but being my carer and being responsible for the decision making, it's all getting a bit too much for her, I think.
Oh, okay. Have you spoken to her about it?
No, but I'm much sicker than I was when I first asked her to be my decision maker. Okay. And I don't want to be a burden to her.
Right. Is there anyone else in your family or anyone else that you would trust that could be an alternate decision maker?
Well, there's my daughter Jodie. She's already doing a lot for us. But she may be willing to take on the decision making.
It sounds like it would be really beneficial for you if we sat down and had a look at all of your advanced care planning documents with you, Cherry, Jodie and your doctor, and just went through it all and ensured that it was all up to date, and that everyone sort of knew their roles and responsibilities and felt comfortable about what you wanted. Is that something that you'd be happy for me to organise? Yeah.
That
Excellent.
sounds good.
Yeah, terrific. When it comes to having a conversation about advanced care planning, it's everyone's responsibility. It's important that you identify when advanced care planning is being considered. You then need to provide them with the information they need and support them to make their own decisions. Finally, support the team around you by communicating what a client might be thinking and noting when changes to someone's plan might be necessary.
So I hope that you've had some thoughts about the video and what that would mean for you as the interpreter, and what it would possibly mean for that client if he was a speaker of your language coming from another country and cultural language background, and not an English speaker like in this video. So here are some findings from the iCanPlan project. This is what they found could be challenges for interpreters working in advanced care planning. So very common challenge across all sorts of different settings, not just in ACP. Interpreters often say that they don't get briefing or debriefing in all sorts of different types of communication. So this also happens in ACP, unfortunately. Sometimes interpreters find that they're working with inexperienced clinicians who might not understand the role of the interpreter. And there are cultural considerations. So you heard Kylie say that there could be a perceived conflict between the Western culture values and the values of the patient and their family. So on one side, we've got typically Western principles of patient autonomy, individual choices and decisions and truth-telling, so very much standouts in ACP communication. But for the patients and their families, these may be at odds with their beliefs and practices. Another type of challenge is maintaining impartiality when the family expects that cancer diagnosis or prognosis shouldn't be disclosed. And sometimes patients ask interpreters for advice, also an ethical challenge for the interpreter, who is expected to be impartial. Then we have interpreting advanced care planning concepts and terminology accurately into LOTE, site translating ACP documents. So we've already touched on those documents. You have an idea of what they look like and where to find them. And finally, a common challenge is an emotional response to end-of-life care content. So as you know, not only in ACP, but generally in cancer care or palliative care as well. So what is the role of clinicians and interpreters? Well, above all, these sessions will work really well if clinicians and interpreters collaborate, if they work closely together. And I'm referring here to a wonderful guide for clinicians working with interpreters in healthcare settings. You've got a link to the website where you can find the full guide here at the bottom of the screen. And I'm just focusing on a couple of aspects mentioned in the guide. So clinicians, according to this guide, should collaborate with interpreters as non-clinical members of a healthcare team. So this is really good to know. They should inform interpreters on the nature of the consultation prior to its commencement, where possible, recognizing the need to assist the interpreter to prepare. So very useful for interpreters. But there are some expectations on interpreters as well, recognized in the guide. So it is recognized that interpreters may take a proactive approach and ask the clinician to brief them, if this is possible, in accordance with the AUSIT Code of Ethics. So this is an agreement with our Code of Ethics, which encourages interpreters to request a briefing and access to reference materials and background information before their work commences. So as an interpreter, you are ethically expected and okayed to actually ask for a briefing when it's not offered to you. And the guide goes on to say that when possible and appropriate, clinicians and interpreters may debrief and exchange feedback following a consultation. So we can learn from each other and we can learn how to work better together in the future. So what can we expect from clinicians? Clinicians' role before the consultation, and that goes both for on-site and remote consultations, is to provide a briefing to the interpreter, including the patient's prognosis and any emotionally charged content likely to arise, so that the interpreter can prepare themselves emotionally for what might be coming up. They can also ask the interpreter about any cultural considerations or insights, so these could be discussed prior to the consultation as well. During the consultation, the clinician will lead the conversation and make decisions about the approach taken and the information shared with the patient and the family. So in the consultation, the clinician decides what is discussed and how it is discussed. They should also explore the patients and their family's perspective, cultural perspective, by asking them direct questions, and appropriately manage any possible expectations, cultural or spiritual, from the patient and their family. And after the consultation, we would like a lot of the time for the clinician to debrief the interpreter. What about interpreters? They have some responsibilities as well. So as stated before, you are very much encouraged to ask for a briefing if it's not offered by the clinician. If we ask often enough, the clinicians will get used to the idea and maybe start offering briefings a little bit more often. During the session, during the briefing session, interpreters can provide some relevant cultural information to the ACP clinician, but we must do that in an objective and non-stereotyping manner. And I've got a little bit more to come on this topic on the next slide. We could also suggest to the clinician that they speak to the patient's family first to hear about their concerns and wishes. We have in the past had some conversations with cancer care clinics and suggested this because often it is a family who have different expectations, and it might be important for the clinician and the family to discuss them first. During the consultation, the interpreter should accurately and impartially interpret whatever is said, including side conversations. So when you've got the patient and the family, they might have some conversations on the side in their language other than English. Your job as the interpreter is to interpret simultaneously those conversations back to the clinician so that they are linguistically present. So whatever is said during the consultation is then subject to interpreting. We have to interpret whatever is said during the consultation. Afterwards, we can ask for a debriefing if needed. You won't always need a debrief, but sometimes you might, and don't be shy. Please come forward and ask. And remember that it is not the interpreter's role to manage the load client's cultural or spiritual expectations. The people we work with might have all sorts of different expectations, but we can't manage them or meet them. We ultimately interpret that communication, whatever choices are made by the clinician. So a little bit about consumer expectations from a cultural and spiritual perspective. So you've already heard about the person-centered approach in advanced care planning. The conversations are about the individual, about their needs and choices. Now, sometimes, as we've already flagged, this might be a different expectation from what happens in other countries and cultures. So there is that cultural dimension, but it's always very important to be aware of the individual dimension, or to be aware of diversity within diversity. So just because people come from the same country, it does not mean that everyone thinks the same way or shares the same cultural or religious practices. We're all different. And migration journey is also an influencing factor. So depending on what the person's journey was like coming into Australia, they would have different experiences and different expectations as well. So as interpreters, we must consider what might be hidden below the surface. You will never know what is hidden below the surface, but be aware that there is that other layer, just like this iceberg image that you're looking at. So we can observe only a small portion of a human by observing their behaviors and characteristics. What we basically can see, what's readily apparent to the casual observer. But all the important stuff is actually hidden below the surface, so the attitudes and the core values. And this is influenced not only by religion, but also by history, the media, the education systems they went through, their family and friends, and who they socialized with, their economical situation as well. So there are a lot of factors contributing to what makes us the human beings that we are. So there is the diversity within diversity that we must always remember. And the other side of the coin is the universal dimension. So what unites us across the different countries and cultures? How is this person like others? And that goes across continents, really. So one thing that I wanted to say to you that we often think that, in my culture, in my country, people can't talk about their parent dying or their loved one dying. But it is true for, I would say, for every country and culture and for most humans. It's not an easy conversation to have. So sometimes we might make assumptions about the mainstream Australian culture because we don't know enough about them. And when we really stop to think about it and to get to know them, we very, very much alike. And these are not easy conversations for English speakers either. For the Australian people living in Australia, it's not easy either. So let's not make assumptions about that. So about managing consumer expectations in advanced care planning. We know that clinicians too, not just the CALD consumers, may have unrealistic expectations about what interpreters can do for them. They often don't know about our ethics and role and how we work. So it's important to remember for you as an interpreter to maintain a professional relationship with clients. This is written into our code of ethics. We should avoid sitting with the loud speakers, not all their families in the waiting area. So basically find spaces where you can sit and wait away from the patient and their family so that you don't get into difficult conversations before the assignment. If you can't avoid these conversations altogether, let's try and make sure that we keep those conversations neutral and impersonal. So the briefing should come from the service provider, not from the patient and their family. And when we do meet the patient and the family, it's important to, or the service provider for that matter, it is important to introduce ourselves as the interpreter and explain our role as an impartial facilitator of communication. We're moving on to terminology. So one of the things that came through the iCanPlan research is some reports that some terminology related to end-of-life care doesn't exist in other languages. So the examples that were given in this research were, the first one was palliative care, which apparently in at least one instance was interpreted as giving up in Mandarin. And the second example was cancer, which apparently was once interpreted as God forbid in Arabic. So the important question for us as professional interpreters to ask ourselves is, are these terms truly absent in the target language, so in the language other than English? And you might find that in some languages, these terms truly do not exist. In other languages, though, they exist, but they could be misinterpreted by the interpreter due to the lack of competence or not enough research. So basically, if you do research that is thorough enough, you might find that some of these terms do exist. You might find some surprises. So first of all, let's deal with our Mandarin and our Arabic example. So I asked my professional colleagues, and I found out that in Chinese, there are two terms for palliative care. Don't ask me to say them. I won't be able to read these characters, but I do know that the literal meaning for the first Mandarin term is relief or mitigation treatment. The second term in Chinese means peaceful care or comfort care. So neither of these back translates to giving up. So I don't know how that happened in the communication that was reported in the research. However, it is true that palliative care is not a well-known concept in mainland China. Now, Arabic, on the other hand, I also got this term from my Arabic-speaking colleague. Apparently in Arabic, in an informal conversation, lay people do not use the formal medical term for cancer. They will say the other disease or the bad disease instead. But interpreters are expected to use the formal medical equivalent. So we need to know that formal medical equivalent when it does exist. And I have to tell you that in Polish, I am in a very privileged position because there are very easily accessible terms for cancer and palliative care that are generally known to the general population. So I have an easy job. But in Dinka, for example, my colleague tells me that many medical terms are absent from the Dinka language. For example, cancer is one of those terms. So interpreting strategies in Dinka will be very different, and we'll come back to that. So how do we work out whether these equivalent terms are truly absent or whether they exist somewhere and we just haven't come across them? It's important to research the concepts and the terminology, and in the context of advanced care planning assignments, to prepare thoroughly for these assignments. So we need to have a look at parallel texts, and I will show you an example so that you know what I mean. But in a nutshell, a parallel text is, so you're looking at a text on advanced care planning in English and you want to find out the terminology in another language, let's say Polish. So you look at a similar text that has been written originally in the Polish language on the same topic. So I'm not talking about translations here because translations are as good as the translator. I'm looking at very similar texts written on the same topic in the two different languages. And once we've done our research, let's develop some glossaries on the topic. We might want to consult our colleagues. They could have the right terminology when we don't. If, like in Dinka, these concepts really do not exist, then we have to alert the service provider and let them explain and be a little bit more descriptive in their communication. So rather than use the medical terminology, and then we can interpret exactly what they're saying if these terms don't exist in our language. So we always have the service provider there to rely on to explain and paraphrase if there is a concept that we're not familiar with or an equivalent concept doesn't exist in our culture, even though we understand what it means. So let's have a look at the a couple of websites, because there are some glossaries out there that which you could check out. So Advanced Care Planning has some glossaries, and Palliative Care Victoria has a glossary of terms as well. The first glossary is monolingual, so you will see terms in English and an explanation in English, which is very useful and plays an important role. And the second lot, the multilingual glossaries, these are the glossaries with translations in different languages. And they're also as good as the translator. So if we look at those, we have to be critical. I'll show you an example of that. So let's have a look at the first one, which is the monolingual. All right, so we're looking here together at the monolingual glossary with explanations in English. And one of the terms here is guardian, which is a term that we were looking at before. So it's got an explanation here. And this one is not the hard one. What I really wanted you to pay attention to is the enduring power of guardianship, or the enduring guardian. And you can see here an enduring guardian could be authorized to make decisions about things such as where the person lives, the support services they have access to, and the treatment they receive. So there's a range of things that the enduring guardian can be authorized to make decisions on. So remember this. So useful resource where we can find a lot of definitions. So the second one that we're going to look at is the Multilingual Glossaries website. And you can see there is a whole range of languages here. So if I, for example, click on Polish, you can see this beautiful looking glossary of terms in Polish. And one of them is advanced care planning. So I'm going to take you through it. And you can already see advanced care planning, 3 words. And the Polish equivalent that's suggested here is 1, 2, 3, 4, 5, 6, 7, 8 words. And sometimes this is legitimate, but in this example, I have to say it's not the best one. So if I back translate that glossary, the Polish translation that I've just shown you, the one with all these words, have a look at, see what the back translation looks like. So advanced care planning was translated there as planowanie wyrażania oświadczeń woli w sprawie opieki w przyszłości. A real mouthful. And what it means is planning expressing declaration of wishes in relation to care in the future. So this is exactly what it means. And I wasn't too happy with that, so I did a little bit more research. And I looked at one of my favorite online dictionaries, Babla. You might be familiar with it. You might have some other favorites. And I found a term that I was a lot happier with. Only 4 words here, and it actually exactly means planning care in advance. So it's a really good term. But then I thought to myself, is this the term that's really functioning and used? I'm happy with it, but let's just double check on it. So I went into some other websites. I can't scroll here, I forgot that. And the first one that I was looking at is Opieka Seniora, which is some general information about care available for older people. And I didn't find an equivalent term there. So I kept researching. And I came across an article, which is a research article, and it gave me exactly the same terminology as the Babla dictionary. So I'll just quickly show you of what a really true parallel text looks like. So it should open the page where I found the PDF, and I'll just show you quickly the PDF of that article. And here is my term for advanced care planning. And you even see it in English, advanced care planning, and over the top of it is planowanie opieki z wyprzedzeniem. And this is perfect. This is the term that I am going to use for advanced care planning. So that just goes to show how sometimes you have to be critical and you have to do a little bit of research to find that perfect term to put in your glossary. And about the enduring guardian, I was luckier and I found the term quicker, but again, I had to be careful with it and understand what it actually means to pick the right term. So another glossary is that I use is Lingway, and it comes up with a whole range of examples that came through translations. So you can have a look and pick the best one. So it's got here enduring guardian, so that's what I'm after. But when I looked at the translation here, it's got the financial power of attorney element to it. And we know, because we've looked at that multilingual glossary, that it is not limited to financial. So I'm going to use elements of this term, but I'm going to skip the financial, because if I was to use this term straight out of the Lingway dictionary, I would be confusing people. So I will say stały pełnomocnik, which means enduring guardian, but it doesn't have that financial element there. So I've gone into a little bit of detail here in this section, I know, but I just wanted to demonstrate in context what thorough terminology research looks like. And of course, it will be different in different languages. Sometimes you won't be able to find good equivalents, and you will need to get the service provider involved in the explanation. There are some more websites with general information that could be useful for your research as well. For example, Advanced Care Planning Australia has information in community languages. So a quick look there. So see, we've got a range of languages here. We haven't looked at Hindi yet, for example. So you will see a brochure here, I believed, in Hindi on advanced care planning. So if you are a Hindi interpreter, have a look through it. You might pick up some relevant terminology and understand the concept a bit better if you read in your own language. And then lastly, Multicultural Communities Council of Illawarra is a fantastic website for when it comes to multilingual resources. For example, they've got the Planning Ahead booklet in 23 languages, and they also have What is ACP videos. So again, something for you to explore in your own time. So booklets in multiple languages, and then at the bottom it's got videos. So we'll just wait for these to load. So for example, you've got advanced care planning in Portuguese, you've got it in Macedonian, and you've got it in some other languages. So here are families having conversations about these topics. So again, very useful research. And finally, we're moving to our last topic. Any conversations about end-of-life care can be difficult and can have an emotional impact on the interpreter. So we know generally from research, not specific to iCanPlan, but to other end-of-life situations or any difficult conversations that you might be interpreting. We know that interpreters often relay difficult, emotional, or confronting conversations. And we do so in the first person when we interpret. So we don't just listen to these conversations, we actually repeat them using the pronoun I and trying to convey the tone of the communication as well. So it has a deeper impact on us than listening might have. So we cognitively process by imagining the client's perspective so that interpreting becomes far more intense than just hearing the words, which is what I was just trying to say. And we may experience emotional fatigue or burnout. So it is very important that we are aware of this fact and that we take active measures to protect ourselves from possible burnout or emotional fatigue. So what can we do about this as an interpreter? First of all, we can ask for a pre-session briefing so that we can prepare for that emotional content, and that makes a difference in itself. We could debrief after some sessions, and that's not just a debrief with a service provider, it's also a debrief with the employee assistance program, for example. We can ask for time out when we need it, and we can also access targeted professional development that raises awareness of the possible impacts of traumatic client content, the concept of vicarious trauma, and the importance of self-care. And these are a couple of examples here. So today we're talking about a broader topic and we're just touching on the emotional aspect of these encounters. But there are some resources and sessions out there that are fully devoted to this particular topic. You're probably accessing this recording on the New South Wales Healthcare Interpreter Service SharePoint, in which case, if you look around, you will also see the PDC webinar on vicarious trauma for healthcare interpreters. Goes for almost 2 hours, and there is a clinical psychologist taking us through the session. So a really good resource. AUSIT, a professional association for spoken language interpreters, also has a webinar, which I have to say I haven't seen yet. I'm going to have a look at it. The topic sounds really interesting. It's navigating the invisible burden, stress and anxiety and self-care for interpreters. So check it out on the AUSIT website. And we do have a video for you today, which we are going to play, and it's key messages about self-care. And when the video stops playing, I will invite Kylie to talk about self-care.
Self-care isn't just about me, it's actually about we. You can't truly serve or care for others without first caring for your own health and well-being. As they say each time you board a flight, put your own mask on first before helping others.
So I think the most important thing is to not lose yourself or forget yourself and be kind and accepting of who you are. This is big work. And I think that's acknowledging that is really, really important.
So my biggest message for self-care is not to neglect your health at the altar of work, to intentionally rest and intentionally replenish your energy.
So my message around self-care would be that practice it before it's too late. Unfortunately, nobody is immune to burnout. I thought I was until it happened to me. If we don't take care of ourselves, we won't have longevity in palliative care, and we won't be of benefit to our clients and our colleagues and our own loved ones for the long haul.
I guess within ourselves there are parts of us that are dying to live and parts of us that are living to die. So that in this last dance with a dying person, if we can pay mindful attention to that, that we find a new aliveness that enriches us in our living, that sustains us in our separateness until we find that moment when we dance together again.
So over to Kylie about self-care examples.
Thank you. And that was a really good video from a number of different perspectives to just really understand how important this is for a range of different healthcare providers in this work. So it was developed by Palliative Care Australia, and the first resource that I've got up there on the page, the Self-Care Matters, has also been developed by that team. And it's got video resources. It's also got some information around maybe some self-assessments. So there are some self-assessments available that if something's just niggling away, you're just not quite feeling yourself, you're not sure should you be going down this path, it's worthwhile just doing a quick self-assessment and seeing how you're traveling in this space as well. And they've got some resources and supports also on that link as well further. Also recommend good national reputable company, or the Black Dog Institute. They've got wellbeing resources as well, again supporting self-care and enhancing wellbeing. There is another national project, LDAC, End of Life Directions in Aged Care. So it is aged care specific. It's a lot of work that's been done, specifically working for care providers working in aged care. And as you can imagine, they are also exposed a lot of the time to these conversations. So there is some relevance around its application at end of life and having these challenging conversations. But they similarly have a self-care room, which has got some quite useful tools to do assessments and also some ideas of how best to support yourself. So I guess just take a moment to have a little bit of a reflection. I've got some examples there on the screen, but what it might be that fills your cup. What is it that perhaps you need to start up again or continue, do a little more to ensure that you're actually looking after yourself? And that is going to be unique to you. So it's really worth taking that time to have a think about what it is that you enjoy and what brings you joy, and you're able to actually get you back on track perhaps, or enable you to continue this really important work that you're part of. So I think just take a moment and reflect. Think about what it is that you love to do. For me, if I don't get out and go for some walks, then I get a little cranky, just clears the head. So I think they're really important things to think about personally.
I love walking too. And yeah, we all have different things that we like. I've spoken to many interpreters in different workshops and found out about interpreters who love gardening, who love dancing, singing, connecting with people, or maybe spending some quiet time and meditating. So lots of things that interpreters do. So think about yourself and what it is that makes you happy.
Definitely.
So I would like to summarize now what we have talked about today. So we know now that advanced care planning considers future healthcare, and it is about the person's choices. They're central to any conversations and then documentation. And advanced care planning supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences. We know that conversations about someone's passing or deteriorating health are not easy for anybody in any culture. So when it comes to culture, it is important to recognize the universal dimension and diversity within diversity and avoid stereotyping. As an interpreter in advanced care planning conversations, make sure that you are prepared, that you study the context and terminology, and that you also ask for briefings. So today's session is a good starting point, but we would expect that you will explore from here and certainly develop your own glossaries and explore the terminology. Once you are in the assignment, make sure that you interpret impartially and accurately all of the communication, including any side conversations between let's say the patient and their family in their language other than English, but it works both ways. So if you've got a couple of service providers and they talk to each other in English, we interpret that communication into the language other than English as well. So accurately interpreting everything in both the content and the tone of the communication. We also know that clients may sometimes have unrealistic expectations about what interpreters can do for them. And by clients, I mean ACP clinicians as well as the non-English speakers. So understand your professional role and ethics and make sure that you maintain professional boundaries and that you explain your role to others when issues occur or even at the start of the communication during the introductions. And if you need support, speak to the clinician, speak to your manager or even a counsellor after the assignment and make sure that you make it a habit to look after yourself and regularly engage in some self-care practices. So Kylie, tell us about some of the key resources.
Yeah, I think everyone is on a learning journey and yours will also continue as you grow and develop more in this space. So I think there are a number of quite reputable websites that I'd recommend if you'd like to continue your learning. The Advanced Care Planning Australia website, we've referred to that a number of times today with some of the language resources, but it also just has very broad general information that you're able to get around advanced care planning and also some ongoing education opportunities as well through the Advanced Care Planning Australia site. If you're interested in understanding a little more about the law that is relevant to advanced care planning, I can't recommend enough the QUT End of Life Law for Clinicians website, and it can drill down into your state-specific information. Very worthwhile to have a look at. And we've referred to the Palliative Care Australia resource and the Self-Care Matters document. And if there's broadly anything that you'd like to understand a little more around, I guess, end-of-life care and palliative care, that would be a good site to start your journey as well in terms of understanding a little bit about that context of care and cancer care. So I think then the next page has just really got a couple more links to the advanced care planning information. One thing to highlight is the National Advanced Care Planning phone line that we have that anyone is able to ring. Health professionals, community members, interpreters, you're able to ring up if you'd like some clarity or ask some questions around advanced care planning. You'll get a person on the end of the line who can provide you some explanations, or we'll escalate that if we need to get the information and follow up with a phone call back to you if needed. And that's the direct link to the Yano micro-learning that if you'd like to do any further learning around advanced care planning. Yeah.
And here are some contacts for iCanPlan project, Professor Reema Harrison and Ash from Macquarie University. And you can find out more about the iCanPlan as well. Now, we would really like to hear from you and find out how you found this program. So there is an evaluation that comes with it. And you can access the survey via the link or the QR code, whatever works better for you. And also a reminder that as usual with all of these programs through the PDC website, there is a quiz to complete. So after you finish the program, please click on the quiz link, which sits outside the PowerPoint. And the quiz pass rate is 70%. So once you have completed the quiz and achieved 70%, please let us know. Please let me know because I don't get automatic notifications of that from the website. And once you let me know via email, I will verify your quiz result and issue you with a certificate of completion, and you will get 10 PD points for participating in this education program. And a couple of references to the study under review and also the vicarious trauma article that I was referring to earlier on. And that's it from us. Thank you very much for engaging with us today, and I hope you learned from this program. And do not forget to provide us with feedback, and also provide us with also do the quiz and let me know when you finished. Thank you very much, and thank you, Kylie, for co-presenting with me.
Thank you. It's a pleasure.